Hello, and good morning or good afternoon wherever you are. Welcome to the third of 6 webinars presented by the Balanced Mind Foundation and made possible by a grant from the American College of Neuropsychopharmacology. My name is Jessica Jimeno, and I am the Online Communications Associate. I will be co-moderating today's webinar along with Nancy Shimon, Program Manager. Joining me are Shira Rader and Julia Small, who will be handling any technical issues you may experience related to the webinar and triaging questions for our guest, Dr. Ellen Leibenluft. Before I get started, I will briefly go over 5 housekeeping items. First, we are recording this webinar, and it will be available on our website in our chat and webinar section. Second, all attendees will be muted during the program to prevent background noise or microphone feedback. Third, we will have time for questions at the end of Dr. Leibenluft's presentation, and you may submit questions in writing at any time during the program. We will try to get to as many as possible, time permitting. Fourth, to submit questions, simply type them into the question box on the left-hand side of your screen. You can write these questions in at any time. Again, we will read them at an appropriate juncture in the presentation. Fifth, if you have technical problems, please let us know through the question box, and Shira will assist you. And now, I'd like to talk about Dr. Leibenluft. She is the Senior Investigator and Chief of the Section on Bipolar Spectrum Disorders in the Emotion and Development Branch, Mood and Anxiety Program of the National Institute of Mental Health. She is also a Clinical Associate Professor of Psychiatry at Georgetown's University School of Medicine. She came to the NIMH in 1989, and since that time she has been conducting research on bipolar disorder. Her research focuses on brain mechanisms involved in bipolar disorder in children and adolescents. Her work involves the use of cognitive neuroscience techniques and neuroimaging modalities, including MRI. Additionally, Dr. Leibenluft has done research aimed at answering the question of whether children with impairing irritability should be diagnosed with bipolar disorder. And now, I would like to start our program. Dr. Leibenluft, we are thrilled to have you with us today.
Thanks very much. It's really a pleasure to be here, and I'm very grateful to the Balanced Mind Foundation for this opportunity and for all the wonderful work that the foundation does. It feels a little strange not being able to see you all out there, but I hope you're all comfortable in your homes or offices, wherever you might be. So today I want to talk about diagnosing mood disorders in youth. And first, in terms of, to give you a broad overview of what I'll be talking about, as many of you, I'm sure, are aware, there have been lots of questions raised about the diagnosis of bipolar disorder in children. And in particular, the question has been raised about whether bipolar disorder looks different in kids than it does in adults, and therefore whether we should use different criteria to diagnose the illness in children than adults. And what I'm going to do is I'm going to describe for you a line of research that we conducted to try to answer this question. And that line of research started with defining a syndrome to capture very irritable children, and we called this syndrome severe mood dysregulation. So I'm going to be describing that to you. And then I'm going to talk about studies that we did to see whether SMD, severe mood dysregulation, and bipolar disorder, whether they're different or the same. And the way that you answer this question in terms of psychiatric illnesses is you look at a couple of things. One thing is you look at what happens to the children as they grow up. And I'll explain more about that. But basically, do children with SMD and bipolar disorder look the same when they grow up or different? You also look at family history, and we can look a bit at what the brain is doing. And then I'll talk a bit at the end about some implications of this for treatment. So this just gives you a very broad overview of what I'm going to be talking about, but I'll go through each thing in a great deal of detail. So, as I said, the question that was raised, it really attracted a lot of attention over the last decade or so, is whether bipolar disorder looks different in children than it does in adults. Now, we know in adults that bipolar disorder is characterized by what are called episodes of mania and depression. And I'm going to explain to you exactly what makes up an episode. But the idea was that this is something which kind of comes and goes, and that's what bipolar disorder is. The new idea that was suggested was that bipolar disorder in youth doesn't have episodes, that children with bipolar disorder, instead of having episodes of mania and episodes of depression, that what they have is very severe irritability that's there all the time. Doesn't come and go at all, but just they're irritable all the time, and in addition that they have symptoms of ADHD. So this was the new idea, that children with bipolar disorder don't have episodes of mania that come and go. Instead, what they have is irritability all the time. And the question that we wanted to ask and answer is this new idea correct? So the first thing, of course, that you really need to understand is what makes an episode. So these are the criteria for a manic episode. Now, probably many of you know that the DSM-4 is the system of diagnoses that's used in psychiatry. And an important thing to know is that there is no such thing as mania in DSM-4. You have bipolar disorder, and of course for bipolar disorder you have manic episodes and depressive episodes. The point is there's no such thing as mania. It's only a manic episode. What makes an episode? There are two things. The first thing is, and I've kind of shortened the language here, but you'll get the idea. The first thing is a distinct period of a mood change, an abnormal mood. And for mania, it's elevated, expansive, or irritable mood that lasts more than a week. But the important point here is it's a distinct period. It's something different. It's not that person's usual mood. So the first thing which makes an episode is this distinct period of a mood change. But it's not just about the mood. At the same time that the child, or the adult for that matter, has this change in mood, at the same time they're supposed to have a certain number of these so-called B criteria. And these are some of the things you think about when you think about mania. Decreased need for sleep, speech going very fast, grandiose ideas, being distractible. But the important thing is that these things all need to start at the same time as the change in mood. Or, like let's say you have a child with ADHD who's distractible all the time, and then they have a change in mood and they have some of these other symptoms. The distractibility has to be distinctly different from that child's baseline. So the two things which make an episode are, number one, a period of a different mood that's different for that person, and number two, that at the same time the person has that different mood, they also have these other same symptoms, either coming on or getting much, much worse at the same time. So it's like a little package deal. Now, what happens if you look very carefully at these criteria for manic episode, you see that there's a lot of overlap with ADHD, with what kids with attention deficit hyperactivity disorder have. As of course everyone would realize just from the name, children with ADHD are very distractible. They often also say sometimes that their thoughts are going fast. They can speak very rapidly. They may not need sleep very much. They certainly can be viewed to be agitated. So what happens here is that there's overlap here, and that the other thing, and this is very important, that a lot of children with ADHD also can be quite irritable. So you can see that if you go ahead and say, okay, children, this was the idea that was advanced. The idea that was advanced that was new is children with bipolar disorder don't have episodes. Instead, what they have is very severe irritability, and then they have a bunch of these other symptoms. And you could see how a child with ADHD who's irritable would meet these kinds of criteria, would have that. And so this was the question. And the important thing to realize is that in children, ADHD and irritability are much, much more common than are episodes of mania. So if we decide that ADHD and irritability is how bipolar disorder presents in children, if that's what we say, and we say we're not going to be looking for episodes of mania, what's going to happen is that the diagnosis of bipolar disorder is going to become much, much more common in children. They're going to be getting the diagnosis a lot more. And so it's important to try to figure out if you've got a child who's got these symptoms of ADHD and irritability but doesn't have episodes, doesn't have times when their mood is different and they've changed, it's important to figure out, is that really bipolar disorder or isn't it? So let me give you an example that might help make this a little bit easier to understand. Let's say that you have a child who gets up in front of the class and says, I'm smarter than the teacher. And let's say that this child is always active. At the same time that they're saying I'm smarter than the teacher, they're running around a lot, they're having difficulty controlling their behavior, they're very distractible, they're talking very fast. Is this ADHD and some oppositional kind of behavior, or is this mania? Well, a very, very important question here is this different for this child? So let's say you have a child who for a long time, a year, several years, has had this kind of behavior in the classroom and at home, has tended to say, I'm smarter than the teacher, has tended to lose their temper a lot when they're told, well, no, you're not the teacher, you got to go do your homework now, or you got to go do your schoolwork. Let's say for years, for a long time, even for many months, this child has been acting this way. And yes, they run around a lot, they have very, very fast speech, but this is very typical for this child. That would not be an episode. What would be an episode is, let's say, this is a child where this isn't typical. This is a child who typically doesn't really have any particular problems in the classroom, or may have a few problems, but certainly nothing where you would expect them to get up in front of the class and say, I'm smarter than the teacher. This is a child where people would look at that and say, this is very unusual. She or he is not acting the way that she or he usually does. And at the same time that this child starts doing things like getting up in front of the class and saying, I'm smarter than the teacher, that child also is sleeping less than usual, is being much more active than usual for him or her, is talking much more rapidly. This is a change. That might be something that you might think about possibly as a manic episode. So a lot of the important question here with episodes is, what's typical for this child? If this kind of behavior is typical for the child, it's hard to call an episode. It really should be different. So remember, though, that a lot of this has to do with irritability. A lot of what this discussion has been in bipolar disorder is if you have a child who's very, very irritable, is that bipolar disorder? And the important thing to know is that irritability is very, very common in children, and particularly in children with psychiatric difficulties. So here you see a list of child psychiatric disorders. And the ones in white, irritability can actually be a symptom of that disorder. Okay, we talked about mania, depression, post-traumatic stress disorder, oppositional defiant disorder. Irritability is a criterion for all of these disorders. The ones in yellow, it's not actually a diagnostic symptom, but it's written in the text of the DSM that you often see it in these children. So children with ADHD, as I mentioned, can very commonly be irritable. Children with autism spectrum disorders can very commonly be irritable. So it's really important to recognize how severe irritability in children is probably one of the most common reasons why children are brought in for psychiatric care. But another important thing to know is that we've actually studied it very little We don't know much about irritability in children at all. We don't really know what it looks like, what's kind of a normal level of irritability at different ages, what happens to it over time, how to measure it, what might be due to genes, what might be due to environment or some interaction between the two of them, the brain mechanisms, and most importantly, we don't really know how to treat it. So one of the major points, I think, that's come out of the talk about the increased recognition of bipolar disorder in children and the talk about it is that we understand now how important irritability is, how little we know, unfortunately, and how much more work we really need to do, particularly around treatment. So, okay, so here we were, and this is about a decade ago, and people were talking, researchers, clinicians were talking, does bipolar disorder look different in children than in adults? And so we said, okay, well, the first thing, how would you address this? How would you figure this out? So the first thing you want to do is you want to define the group of children that people aren't sure where to place them. And those children, as I said, are these children who have severe chronic irritability. They don't have episodes, no episodes, but they have a lot of outbursts and a lot of crankiness, and they have ADHD symptoms. And they're that way, they're cranky all the time, or most of the time. It's not a change, it's not different. This child has been this way for a very long time. So there was no category for these children. They're sort of like oppositional defiant disorder, but not exactly. So we created this category for them called severe mood dysregulation, or SMD. And I'll show you the criteria in just a minute. But we said, okay, so what we'll do is we'll define this group of children, this SMD group of children, and we'll compare them to another group of children who clearly do have manic episodes, who clearly do have periods of time when people will say, this child is really different from their usual now, and this different goes on for at least a couple of days. So we'll take these two groups and we'll compare them to each other. And in that way, because these children, the ones with clear episodes, everybody would agree those children have bipolar disorder. It looks like classic bipolar disorder. It looks like adults with bipolar disorder. So we'll compare these two groups, and if the SMD children look the same over time as the children with episodes, we'll say, well, this is a form of bipolar disorder. A very important question is what happens to the children as they grow up. In particular, do these children with SMD, these children who don't have episodes, they're just cranky and irritable, but severely cranky and irritable, do they grow up to have episodes of mania? Over time, do they look more and more like adults with bipolar disorder? If they do, then we would say, okay, this probably is a form of bipolar disorder. If they don't, it's harder to make the argument that the SMD children have bipolar disorder. Same thing with family history. We know that bipolar disorder runs in families. So if SMD, if this irritability, severe irritability without episodes, is a form of bipolar disorder, then you would expect children with SMD to have strong family histories of bipolar disorder, the same way that children with bipolar disorder have strong family histories of bipolar disorder. So that's another way you look at this. If the SMD children don't have strong family histories of bipolar disorder, then that's another bit of evidence that maybe we shouldn't be thinking of them as bipolar. And then the third thing has to do with brain mechanism. But as I'll talk about later, this is much more out there in the research realm because we really can't use imaging techniques at this point to make diagnoses. So how did we define SMD? Well, the first thing we said was that we wanted children who had these symptoms that didn't have episodes, that the symptoms, the irritability that they had was present for at least a year. And as I'll show you, it's usually present for much, much more than that. No episodes. And we wanted them to be very irritable because that's what everybody was talking about. Everybody was saying that children with severe irritability have bipolar disorder. So we wanted to define irritability. And the first thing we said, and this is the kind of fancy language, increased reactivity to negative emotional stimuli at least 3 times a week. What does that mean? It means these terrible temper outbursts when the kids just can't tolerate frustration, that they're having these kinds of outbursts at least 3 times a week. And that in between these outbursts, they're very angry and sad. Or sad. So irritability is basically these outbursts, these temper tantrums, and in between this terrible anger or sadness. We also said that the irritability had to be impairing, and it had to be impairing in at least 2 settings. If you think of 3 settings, home, school, and with friends, then in at least 2 of these 3 settings, the children had to be impaired. We didn't want necessarily to just have children who are impaired in just one setting, because children with bipolar disorder aren't just impaired in one setting. Children with bipolar disorder have difficulty at home and at school and with peers. And we wanted to be looking at a group of children, with these SMD children, we wanted to be looking at a group of children who are as sick as the children with bipolar disorder. We wanted a group of children who also, like the children with bipolar disorder, have a very, very severe mood disorder. And as you all know, sometimes a child can have lots of trouble in school and be fine elsewhere because school happens to be a particularly bad fit, or they've got a teacher that they really don't get along with, or they can be having more trouble at home because there happens to be a lot of stress at home at a particular period in time. But we wanted children where it was very pervasive, and throughout they were having a great deal of difficulty. We wanted them to have these ADHD symptoms for the reasons that I showed you before, because of this overlap between the ADHD symptoms and these criteria for mania. And it's important to recognize that this group of severely mood dysregulated children, these SMD children, they don't fit well in the DSM-4. And there is this new proposed category for them, disruptive mood dysregulation disorder, or DMDD, that we can talk about if you want. But the important point is there really isn't a good home for them. In the current DSM, they almost all would fit for ADHD and for oppositional defiant disorder, but they're the most severely impaired, the most severely ill of those children. So throughout the rest of the time when I'm talking, when I say SMD, I'm talking about children who do not have any episodes, but instead what they have is very severe irritability day in and day out. When I say bipolar disorder, I'm talking about children who have very clear episodes of mania. And those are the terms I'm going to be using throughout the time when I'm talking. So, and I do want to emphasize that whether or not these children with SMD have bipolar disorder, they clearly have a very severe mood disorder. They are as ill as the children with bipolar disorder. We need to understand in both of these groups of children what's happening with their brain, how we can help them, how to treat them. Both of these groups are very, very deserving of our attention and really do need care. And I don't have to tell this audience, present a great deal of challenge to parents and to families and the children themselves. Both of these groups are suffering quite a bit, the children with SMD and those with bipolar disorder. So what happens to children with SMD or severe irritability when they grow up? Do they develop manic episodes? So we've looked at this in large studies based in the community. And what happens is, this is the answer, that children who are irritable, when they grow up, they're at increased risk for anxiety disorders, and they're at increased risk for depression, for unipolar major depression, not bipolar disorder. Irritability in youth, the community-based studies tell us that irritability in youth does not predict bipolar disorder in adulthood. They do not grow up to have manic episodes. And some of these children have been followed for as long as 20 years, well into adulthood. In our own group, we followed 84 children with SMD over 2 years, and one developed an episode, a soft kind of episode, a mild episode of hypomania. Just one. So really the data are that children with SMD do not grow up to have bipolar disorder. Family history. As I mentioned, we know that children with bipolar disorder tend to have a family history of bipolar disorder. Not all of them, but compared to children without bipolar disorder, they're more likely to have a family history of bipolar disorder. So we looked at this in children with SMD, and what we found is that children with SMD are not particularly likely to have a family history of bipolar disorder. So again, this, like the data about what happens to the children when they grow up, indicate to us that we probably really shouldn't be thinking about these SMD children as having bipolar disorder. What they have may be related in some way to bipolar disorder, but that there's a lot that's different between them and children who have bipolar disorder. So now brain imaging. And first, before we do that, let me just tell you a little bit more about the children that we've studied. And you can see this is the number of children with bipolar disorder that we've studied, the number of SMD children. It's actually up, it's actually now moved into like 150 or so in both groups. So first notice that both of these groups are, when they come to us, about age 12 or so. But this is the age of onset. How old were they when they first developed bipolar disorder? The bipolar, or their illness, first developed their illness. The bipolar disorder group was about age 10 or so. The SMD group was much younger when they first developed their very severe irritability. The parents are reporting very severe irritability from age 5 or 6. Many of these children had severe difficulty in preschool, had to switch school situations, went to see psychologists from a very early age. Notice that whereas bipolar disorder in children is about half and half in terms of gender, and that's what you'd expect in adults, the SMD is more common in boys. Not rare in girls. I mean, 70% is boys, but we definitely do see girls. It's just more common. And again, by the way, I should say that if you look in the community studies, this is much, much more common than this. Then, if you look at what's their DSM diagnosis, it's what I said. It doesn't surprise us that most of them meet criteria for ADHD, oppositional defiant, but this may surprise you. Many of these children, these severely irritable children, have a great deal of anxiety. It may not surprise some of you too, but others, we think of these children as having a behavior problem, but they have a mood problem. These children may be very irritable. They're really struggling with their temper, but they're also struggling with their fears and their anxieties. And this is very important. And these three down here, excuse me one second. These three down here, you remember that I said that we were looking to define a group of children that were as ill as the children with bipolar disorder. And what these variables show you is that, in fact, this is true. 40% of the children with SMD have been psychiatrically hospitalized before the age of 12. And you all know, I don't need to tell this audience at all, that that shows a very, very high level of impairment. So this goes back to what I said before. Both of these groups of children exist. They're both very ill. They both need considerable treatment and care. So how do we begin to try to understand what's going on in the brains of these children? Well, first we want to know a little bit more about how they deal with emotional stimuli in the world around them. And as humans, we're very, very social beings. And so some of the most important social stimuli for us are faces, other human beings' faces. So one of the things that we've done is to look at how these children with bipolar disorder and these children with SMD, how do they process emotion on the faces of the children around them and adults around them. And so this is a very, very simple task. We show them a face of an adult or a child, and we ask them, is this person happy, sad, angry, or fearful? And these are the data that we get. And what you've got plotted here is number of errors. So the higher the bar, the more errors the children make. And this is when they're looking at adult faces. This is when they're looking at child faces. And in red here is the children with bipolar disorder. In green here is the children with SMD. In blue are healthy children. And so you can see when looking at adult faces, both the SMD and the bipolar children make more errors identifying the emotion. The same thing is true on the child faces. What's interesting here is this kind of yellow bar here is children with depression and anxiety, and this is children with ADHD. This gold bar is ADHD. So these children actually are doing okay with this. It's basically our two groups of children that are having trouble identifying the emotion on the faces of the adults and the children that they see. So what we wanted to do is to understand what's going on in the brain that this is happening. And to do that, we use functional MRI or fMRI. And it's very, very exciting research technique because it allows us to really see the living brain at work. And how it actually works, and of course we won't get into the details of it, but hemoglobin in your blood carries oxygen. And basically this is a big magnet. And it can tell the difference between hemoglobin that has the oxygen on it and hemoglobin that doesn't have the oxygen on it. It can tell the magnetic difference. And so by doing that, it can tell which of the brain cells are using oxygen and are doing their work. Now, the really important thing to know is that there are no needles and there's no radiation. So this is basically safe and comfortable for children. Now, of course, when we do it, it's a research technique. And I'm going to go right down to this. Brain imaging cannot be used for diagnosis now. It's a research technique that we're using. So, of course, we only do this with children who are interested in doing it and want to do it. And, in fact, when they're inside the magnet, we can talk to them. They can talk to us. They can tell us how they're feeling, etc. So it's not only safe, but it's important that it be comfortable for the children. But what we do, so we've noticed, as I said, we've demonstrated that both children with SMD and those with bipolar disorder have difficulty labeling face emotions accurately. So we want to use these imaging techniques to see, are the brain mechanisms the same between these two groups? Brain imaging cannot be used for diagnosis now. Eventually, it will be able to be used as a diagnostic aid, not to replace interviewing. I don't think it will ever be used to replace interviewing, but to complement it. The same way that if you see a medical doctor, they may order an x-ray, but before they do that, they talk to you about what's hurting you and how long you've had this problem, etc., so forth. Same thing in psychiatry. Eventually, we'll be able to use this as a diagnostic aid, but not yet. And also, if we understand more about how the brain works and what's going wrong in the brains of these children, that'll give us ideas for lots of new treatments. So those are really, there are a number of reasons why we do these kinds of studies. So for this first study, what happens is children lie in the scanner and they see a face like this, which really doesn't have any expression on it. And we ask them some different questions about the face. How hostile or how angry is this person? How afraid are you? And how wide is the nose? How wide is the nose is sort of the comparison, right? It doesn't have any emotion. Here we're asking, what's the emotion on the face? Here we're asking, what's the emotion that you're feeling? And here we're asking something not having to do with emotion. And we can look at how the brain is functioning while the children answer these questions. They answer the questions by pushing a button while they lie inside the scanner. And this just shows you what they said about how afraid they are. And remember, these are neutral faces. And again, we have the same thing. Both the bipolar children and the SMD children are more afraid of these neutral faces than are children with ADHD or healthy controls. These ADHD children are not irritable. These children have ADHD, but they're very irritable, the SMD children. These do not have irritability. Notice that what's happening is our two groups of patients are walking around the world, and they're seeing faces that other children aren't afraid of, and they're afraid of them. So it really is important to begin to understand how they're experiencing their world emotionally, and then what's going on in the brain. And this is a part of the brain called the amygdala. that, and we're looking at the brain 3 different ways. It's the same brain, it's sliced 3 different ways. And I guess this is a disadvantage where you can't see me because I show you on my head where this was. This is a sideways view. This is kind of a view that where you would cut it perpendicular to the ground, and here you would cut it horizontally. But let's look at this one because this is easiest. And this is an area called the amygdala. And the amygdala is very important in terms of telling us what should we pay attention to emotionally in our world. What emotional cues in our world around us now are important and we should pay attention. And this shows us that across these different groups of children, these groups, the healthy controls, the children with ADHD but without irritability, the bipolar children, and the SMD children, that here in the amygdala, this is again the same picture, just a different color. Here in the amygdala, the activity is different. And in particular, notice here that these SMD children have lower activity, actually. And they differ not only from controls, they differ from the children with ADHD, and they differ from the bipolar children. Okay? So again, just to say, is bipolar and SMD the same? Well, this is some evidence it's not. Again, it's not as strong evidence as what happens when the kids grow up. It's not as strong. That's probably the strongest, and second strongest would be family history. This isn't as strong because we can't use these kinds of data yet to make diagnoses. But still, it gives us a hint that what's going on in the brains of children with SMD is different than what's going on in the brains of children who have clear episodes of mania. Now, interesting, notice that this is going down, that they have what's called decreased activity here in the amygdala. This is another study looking at children with depression, and they also had decreased amygdala activity. And remember that I told you that the SMD children grow up to be at increased risk for depression. So maybe this means something. Maybe this shows us that even before they have the depression, something in their brain is more like a child with depression than it is like a child with bipolar disorder. And then I'm just going to show you a little bit about the brain mechanisms of frustration. I'm going to go through this a little bit more quickly so that I'm sure we have lots of time to answer your questions. So this is, it's a different kinds of imaging technique, but what we do is we have these different kinds of tasks we give children that become frustrating. And they're not any more frustrating than what these children experience in their outside life. Actually, they're less frustrating than that, but they are frustrating. And the reason that we do that, and of course we do it very carefully, and we talk to them about what we're going to be doing, etc., both before and after, but the reason we do it is because if we can see the child's brain when they're frustrated and compare it to the brain of children who don't have such difficulties with frustration and irritability, then that can really help us begin to understand what's going on. And so this is a task where they play this game, and they play it 3 times. And the first time they just play it, the second time they win or lose money, and the third time they end up losing all of the money because it's rigged. Now, I should say that we give them all the money in the end, and that we tell them beforehand that it may not be quite straightforward all that we do, and afterwards we tell them, you know, you really were going to lose all the money here, and we're giving it back to you now, etc. So we explain it to them. But that's part of the frustration. So what I want you to look at, this is a measure of what's happening to attention. What's happening when the children are trying to pay attention. And I want you to start by looking at this blue line, which is healthy children. And notice how it goes up, how this goes up when they're frustrated. When they're frustrated, they're trying to concentrate harder and harder. They're kind of thinking, if I could only pay more attention to this, it wouldn't be so frustrating. I would get it right. I would be able to win all this money. Look at the bipolar children here. They just are flat. And the hypothesis, we don't know for sure, but the hypothesis is that they're distracted. They're so distracted by how frustrated that they are that they can't pay attention here. And so they're different. Notice here, here's the SMD children, again in green. They look like the controls. They look different from the bipolars. So what I'm trying to say here is that both this group, the SMD kids and the bipolar kids, we asked them how frustrated you are you? Both of these groups said, we're more frustrated than the control kids are. We showed that. But what's going on in their brain is different. Now, there's another thing. It's not like these kids are healthy, the SMD kids. There's other ways, other attentional problems that they have. But the point here is that you can have two groups of children, both of whom can get irritable, both of whom can get very frustrated, but what's going on in their brain is different. So finally, what does it matter? Well, it matters possibly because of treatment. If you think that a child without episodes but a lot of irritability has bipolar disorder, then the treatment with bipolar disorder is antipsychotic medication and anticonvulsant medication or mood stabilizers. If, on the other hand, you think that a child with this chronic irritability doesn't have bipolar disorder, but instead has ADHD and has anxiety or a form of depression, then you would treat them with stimulants for their ADHD, and you would treat them with the so-called serotonergic reuptake inhibitors like citalopram or Celexa or Lexapro or Prozac, Zoloft, some of these. You would use those kinds of medications instead of these medications. And this is particularly important because stimulants in the SRIs can make someone with bipolar disorder worse. So oftentimes, people are reluctant with an irritable child to treat them with stimulants and SRIs, even if the child's very, very anxious. And we know that SRIs work very, very well for children with anxiety. But people may be reluctant because they say, oh, well, this is bipolar disorder, and it wouldn't be safe. Now, here's a very, very important point. We do not know for sure that stimulants and SRIs will help children with SMD. We are currently testing that at the NIMH, and I'll show you at the end some information about how you can contact us if you're interested in participating in that. So we don't exactly know yet the best treatment for children with SMD, but the point here is that we shouldn't necessarily assume that children must be treated with antipsychotic medication and anticonvulsants. Some of these children may do well on some of these other medications which tend to have less side effects. So this is a very, very important issue. So, just in summary, severe non-episodic irritability, or SMD, differs from episodic bipolar disorder in longitudinal course, in that the SMD children are at risk to develop unipolar depression and anxiety when they grow up, not bipolar disorder, differs in family history, and differs in brain mechanisms. Both SMD and bipolar disorder are very severe mood disorders. Both bipolar and SMD have deficits in face emotion labeling, and they have trouble with frustration, but the brain mechanisms appear to differ between groups. We need much, much more research on severe irritability, especially on treatment. Thank you for listening. And I particularly want to thank the children and parents who participate in our studies. Here's a very special shout out to you, because we obviously couldn't do all this work, and they make it all worthwhile and all possible. We are studying children with bipolar disorder, we're studying children with severe mood dysregulation, and we're studying children who are at risk for bipolar disorder if they have either a parent or a sibling with bipolar disorder. Here's the phone number. You can just call us up and talk to us, 301-496-8381. We're also at bipolarkids@mail.nih.gov. We have a lot of non-treatment studies where the children come in for the scanning. We also have treatment studies. We take people from all over the country. We, of course, pay for the travel expenses, etc. If you have any questions, just feel free to give us a call. So thanks again, and I can take some questions now.
Thanks, Doctor. We do have some questions. The first is, how long does an episode have to last in a child to be considered bipolar?
So that's a really important question. The way that the criteria are now, it's the same for children as in adults, which is to say that at least 4 days for what's called hypomania, 7 days for what's called mania. There's a lot of interest and we're still learning a lot about children with shorter episodes. It does seem that children who have shorter episodes, maybe let's say a day or two, are at increased risk to develop bipolar disorder as time goes on. But it's important not to confuse a temper outburst with an episode. So something which is basically the child kind of being out of control for an hour or even possibly for several hours, that's very, very unclear whether you should call a child like that bipolar disorder. Certainly we would not. In our group, we would not consider that to be bipolar disorder. And if it's if it's a temper outburst, it shouldn't be confused with an episode.
Thank you. The next question is, what is the difference between rapid cycling bipolar disorder and SMD?
That's another really great question. Rapid cycling bipolar disorder is a form of bipolar disorder. That means that really the term should be used for people who at some point in their life have had an episode that meets the full duration criteria. So a person with rapid cycling bipolar disorder, the technical definition is 4 or more episodes in a year. Many of them have many more episodes, but you shouldn't, they should have had a 4-day episode, a 7-day episode. They might have some brief episodes, but it shouldn't all just be like an hour or two, even sort of a day or two. If you really want to be sure that this is bipolar disorder, there should be some episodes that have lasted 3-4 days, something in there.
Okay. Can SMD run in families?
That's a great question, and we don't know the answer to it. Certainly there is, and you remember I said early on that there's a lot more that we need to know about irritability, or another way of putting it, a lot more we need to know about SMD. There is some literature now just emerging that there is a genetic component to irritability, that irritability does tend to run in families, not as strongly as bipolar disorder does. So there's what's called heritability. The heritability of bipolar disorder is like 0.8, which is very high. In irritability, it would be more like 0.3 or 0.4. 0.3 or 0.4 is about how heritable anxiety disorders are, or major depression is. So it's still genetic, but it's not as genetic as bipolar disorder. That's at least what the early literature leads us to believe.
Thank you. Another question is, can SMD look psychotic sometimes, for example, hallucinations?
That's a really interesting question, too. The way that we defined SMD, we did not include children who have psychosis. And once you have psychosis, that does tend to predict more. Well, it depends. First of all, psychosis, to identify psychosis in children, you have to be careful because children can have hallucinations that are within the realm of normal. So you want to be very careful that these really are what we would consider true hallucinations, and it's trickier in kids than it is in adults to answer that question. If it is true hallucinations, then that tends not to predict as much to like anxiety and major depression, but more to bipolar disorder and some other illnesses.
Okay. The next question is, how do symptoms of anxiety fit into the distinction between SMD and bipolar?
Another great question. Both of these groups of kids can have lots of anxiety. The bipolar children can have anxiety when they're in an episode or when they're out of an episode. Anxiety is very common in both adults and children with bipolar disorder, anywhere from 40 to 60%. So really I would say that anxiety is very common in both of these groups.
Okay. The next question is, what are your thoughts on combining antipsychotic meds with stimulants and/or SRI medication?
Well, and I'm assuming this is in SMD type children. That is something, first of all, of course, we can't talk about, it's hard to talk about things in general, and every child is different. And the most important thing is to have a really, really good assessment and to be clear that the treatment is being delivered very systematically so that the doctor is following with you very carefully whether the child, each time a medication is added, whether the child really gets better or not. I know that many of you parents keep records, day to day. That's really wonderful to do. So that's the most important thing, is that it be done very systematically, very carefully, with a lot of input from you. We do, in these SMD children, we do have some children where we do end up adding on an atypical antipsychotic in addition to the stimulant and the SRI. And sometimes we even then end up stopping, say, the SRI. So that is something that we sometimes do. But part of what people should think about is, what do they start with, and do they go directly to an atypical antipsychotic? And for some children, that might be exactly the right thing to do. That might be absolutely the right thing to do, but it's important to also consider other options.
Yeah, you're not...
Hi, Dr. Leibenluft. This is Nancy Shimon. I had a question as a follow-up on the SSRI usage. We know that for some kids, when they're treated with an SSRI, that they respond with increased rage or mania. Do you have any studies on, or any experience on how that plays out in kids with SMD?
Oh, thank you so much for asking that. That's a really great question. It is very important to distinguish increased irritability on SRIs from true mania. True mania in response to SRIs is actually very rare in both children and adults. Increased activation, which can include getting more irritable, is much more common. We have found that if we start with a low dose, go slowly and carefully, that we have not had difficulties with that. Now, you have to be careful about it, but it is very unusual for a child, SMD or not, it's unusual for a child to develop mania on SRIs. The activation is very common. It's common in children with anxiety. In the large studies they did of anxious children, the SRIs worked well, but there were a fairly large number of children who got some activation and even some irritability, and often that responded fine to lowering the dose. So it's important to separate out true mania from activation. We're very, very careful about that. We're very mindful of that. It really has not been a major problem in these SMD children, but we are conservative in how we dose and very careful.
Okay, thank you. We just have a few more questions. One is, since the age of onset looked at has been around 12 years old, how has puberty played a role in what symptoms we are seeing, and how medications are altered to not over-medicate yet control behavior?
That's another great question. First of all, it's not that the onset was at age 12 with these kids. That's the age at which we see them. The onset of SMD appears to be much, much earlier. It appears to be like age 5, 6, around there. The onset of bipolar disorder, the children in our population, the average age of onset is around 10. In the population at large, if you look at all bipolars, it tends to be later. And there, it really is true that puberty may play a role. There are a number of psychiatric illnesses that tend to have their onset in puberty. Bipolar is one of them. Major depression is another. It appears that SMD is not, that SMD is earlier. We don't really understand why it is that children are at increased risk for these illnesses in puberty, whether it is something hormonal, whether it is that they also face increased stress. they're on their own and, of course, can engage in more risky behaviors, including in some instances substance abuse. It may be a combination of all of these things. And unfortunately, we don't know enough about how to how we might need to adjust medication in response to puberty or in association with puberty. Again, the most important thing is very individualized treatment, that the doctor be following very carefully so as the child changes, the doctor can adjust the medication and other treatments. The other thing to mention is that puberty is a very important time also to be thinking about psychosocial kinds of treatments, because obviously this is a time when children go through a lot of changes, and it can really help with that. I think throughout, and we've only talked about medication, but for both SMD children and bipolar children, there's a lot to be gained from non-pharmacological treatments, from psychosocial treatments.
Okay. On that note, is SMD a permanent condition?
Excellent question. We don't know. We're not convinced that it is, actually. We're looking at some data now to try to figure that out. So I really can't give you an answer. But whereas with bipolar disorder, it does seem that, bipolar disorder is a lifelong condition, we're not sure about SMD. There may be a percentage of kids with SMD who, kind of develop their way out of it. We really don't know, but that's, again, another reason to not assume necessarily that these children are bipolar.
Okay. If you used an SRI in a child with SMD and he began to display increased rages and what appears to be rapid cycling, would that alone lead you to change the diagnosis to bipolar disorder?
No. First of all, again, I'd want to know what you mean by rapid cycling. If you mean increased irritability and being more labile, that's not really rapid cycling. Rapid cycling really is episodes. And remember that episodes are more than just mood, that they're also activity and sleep, and some of those things can be hard to see if they're not lasting over a certain period of time. So, again, to actually see frank mania in response to SRIs is relatively rare. So if we saw a child who got more irritable on an SRI, their mood started, just getting more difficult, we would not at all assume that that child had bipolar disorder. And as I mentioned before, sometimes you can even lower the dose or switch medications and help the child still. Again, you need to be very, very careful with this and cautious, but we would not necessarily assume that.
Okay, we just have one final question. This person asks, to be considered for the clinical center in Bethsaida, must you already live in the U.S.? We live in Canada, but would love to be considered.
Why don't you give us a call, and we'll see. I think the rules have been in a bit of flux over time, and we'd have to look into it again, but just feel free. Anyone who has any questions about the study, about, you don't know whether, we don't expect you to know whether or not your child would be eligible. We do a lot of the screening on the telephone, so there's a good bit that we do on the telephone before we ever bring people in. So anyone who has any kind of questions, just wants to know more about the study, just feel free to go ahead and give us a call. 301-496-8381.
Can we repeat the phone number one last time before we...
Sure, 301-496-8381. And you leave a message and we'll get back to you.
Thank you, Dr. Leibenluft, for your time. We learned so much.
And thank you all for your great questions and for your attention.
Okay. That's the end of the webinar.